looks like across our systems and institutions. And on 3 of the next 4 weeks, we will look at 3 of those systems with people directly involved with those systems in our own community, acting as our panelists. And today we will look at our health system and its disparities. Excuse me. And we have 3 panelists with us this morning. And one of those is Carter Everson. And Dr. Everson is a dentist practicing at Division Dental in Oak Ridge. She grew up in Kingston, Jamaica. She received her Bachelor of Science in Biology from Boston College, her Doctor of Dental Surgery from Marquette, and completed a general practice residency at the UT Medical Center. And Kerri became a member of Ascension. It's been here for several years now, and is also a member of our Becoming Beloved Community Task Force. Dr. Keith Gray is Chief Medical Officer and Associate Professor and Chief of the Surgical Oncology Unit at the UT Medical Center. He's a native of North Carolina, did his undergraduate work in med school at Wake Forest, and followed that with an internship and residency at Vanderbilt and a fellowship at MD Anderson Cancer Center in Houston, Texas. He came to the UT Med Center in 2007. In 2014, Dr. Gray received a physician's MBA degree from UTK. And he's board certified by the American Board of Surgery. And also there's a list of honors and societies and professionals organizations as long as your arm on his vita at the UT Med Center, if you want to look all that up. And Doug Leahy, Dr. Leahy is with the Internal Medicine Associates in Knoxville. That's a division of Summit Medical Group. He received his BS from UTK, his MD from the UT Med Center in Memphis, where he served his residency and a fellowship in cardiology. Doug also has a very long list of honor societies and professional and civic organizations. He's board certified by the American Board of Internal Medicine, and he's a longtime member of Ascension. Be good when we get back together at the church house to see Doug over there in the old transept with his wife, like all the rest of you out there. Pass this on to Mary Ann now.
Thank you, Jim. So thank you all for being here. As Jim mentioned, there was an REI presentation in early January that many parishioners were part of. And it was really just a superb way of laying out the evidence on racial inequality in our country. And so in preparing for today's discussion with our panelists, we thought it would be best to first just share some of those data with you. And I'm going to be very brief because the panelists are what we're here for, but we wanted to sort of level set and just share some statistics so that we all sort of understand what we're talking about. So first, the discussion of health and healthcare disparities begins with differences in life expectancy. And Black men had the lowest life expectancy of any demographic group in the US, and those gaps are growing. Life expectancy for Black women is higher than for Black men, but it's still almost 5 years less than for white women. Many of you probably saw the headline last week suggesting that Black Americans lost on average 2.7 years of life expectancy in the first half of 2020. That means that a Black man in 2020 went from an expectation of living more than 70 years to an expectation of 68.3 years. White men, in contrast, could expect to live 76 years prior to COVID and 75 and a half years after. And as a result, the gap between Black and white life expectancies is now the highest it's been in more than 30 years. It's now common knowledge, I think, that COVID has had an outsized impact on racial minorities, and this slide really brings the point home. The hospitalization rate for Black and Hispanic Americans nationwide is nearly 5 times the rate for white Americans as a result of COVID, at least through late summer 2020 when this slide was produced. In the state of Tennessee, the share of deaths from COVID-19 incurred by Black Tennesseans is double their share of the overall population, making us one of the worst states in the country on this metric. And despite this outsized impact, a recent study from the Pew Research Center suggests that only 54% of Black patients expect to get the COVID-19 vaccine, compared to 74% of white patients. Now, although COVID and the events of Austin East in the last few weeks might lead us to conclude that differences in death rates are due to difference in violent deaths or deaths from infectious disease, that would be incorrect. The majority of the difference in life expectancy between Black and white Americans is due to chronic diseases like heart disease, cancer, and diabetes. We know that Black Americans are less likely to engage in preventive care, including vaccinations, but also to partake in cancer or diabetes screenings, or even to get regular checkups. New research suggests that one of the solutions to these problems is the availability of Black physicians. When Black Americans have a Black physician, they are more likely to engage in preventive care. Unfortunately, Black doctors are quite rare. The circled bars here tell you that although Black Americans are more than 12% of the US population, they are 7% of medical school graduates and 4% of practicing physicians. Another way to see the health disparities in action, so to speak, is to look at infant mortality rates. And infant mortality is especially high among Black mothers, as much as 3 times as high. And those differences are not accounted for by age, by economic condition, or by the education level of these mothers. For example, this is one of the starkest slides from the REI presentation in January. If you just compare within an education level, and you compare white mothers to Black mothers, you'll still find infant mortality rates among Black mothers that are twice the rate for white women with the same level of education. It's just really remarkable. Finally, we're going to talk a little today about public policy. And so it's worth pointing out that Black Americans are far more dependent on the public healthcare system than are white Americans, and somewhat more likely to be uninsured. 34% of Black Americans rely on Medicaid, compared to 15% of white Americans. So with that background, I'm going to stop sharing, and then I'm going to ask our panelists each to make an opening statement. And so they're, just anything they want to make sure that we get to in this conversation. As they do that, please start putting your questions in the chat. I have some already teed up, but I want to know what you want to hear from our panelists. So in the chat, put in your questions. And then I'm going to encourage all of you, you can use the gallery view that many of you are probably currently using to see this presentation. It might be more effective in this setup to change your view to speaker view. So in the upper right-hand corner of your screen, there's a view button. And if you push on that, you can choose speaker view, which will then highlight just the person speaking rather than the entire grid. It's up to you. Okay, so let the panelists introduce themselves and make their opening statement. Dr. Everson, Kerri Everson, if you want to go first.
Good morning, everybody. It's great to see you all again. I just want to say thank you for the opportunity to engage in this forum on the racial disparity in healthcare. This is, as we all know, an age-old problem that this country has tackled, probably since its inception. And I think it's really only when we bring awareness to the problem that we hopefully in this forum will be able to put the wheels in motion to come up with solutions and, at least put ourselves in a different frame of mind as we all leave this forum to kind of make a difference in this issue.
Thank you. Dr. Leahy.
Yes, thank you. Again, I appreciate the opportunity to be involved as well. I think when you look at this issue of healthcare and racial disparity, it doesn't live in a vacuum. And the first thing I think we need to look at is the Medicaid expansion or lack thereof. I refer to Bill Lyons' article in the paper, the editorial this morning, for the nuance, but essentially we've moved to a block grant. It's not clear that that will be passed. There's 300,000 people without health care that would be benefited from it. The second thing is an understanding of the essential worker, which often involves the Black community and others of the underserved communities who do not have availability to do work at home, and therefore they've been positioned into these areas where there's increased sense of COVID activity. In addition, their transportation needs lead to public transportation, and that's a complication as well. I think you have to also look at the issue of living arrangements, home security. For example, only 44% nationally of Blacks own their home, and a lot of times this inability to have home security is crucial. I think the other area you have to look at is the issue of nutrition. A lot of times the Black community does not have adequate nutrition, and it's crucial that that be looked at in terms of this. I think Dr. Gray and others have pointed out that part of this has to do with health literacy. It's important to have the clergies and the churches and other people in the community, and there's been talk of even navigators to help people understand the importance of moving forward and taking care of their health and understanding the importance, particularly with chronic disease. I would argue, however, Mariana mentioned this, I think gun violence has got to be looked at in terms of what happens in the community, because it's been so much involved, particularly the young Black in the community, and we've seen this last week or so. So I think Mayor Kincannon has an article this morning, an editorial in the paper addressing that as well. So I think when you look at this, I think all of us have to look at, doesn't live in just the vacuum of healthcare, but it's the nuance of the community and the stresses of the community that we need to address in a much larger forum. Thank you.
Dr. Gray.
Yes, thank you. And again, it's a pleasure to be a part of this forum and to have this conversation. You know, this is Black History Month, and I was having a conversation with my wife. I'm in South Carolina with my kids, who are students here at the University of South Carolina, and we had the conversation on the way here that, you know, hopefully we will see a day when Black History Month is no longer needed or celebrated, because it will be considered a part of American history. And so I think, you know, I'm all about describing the problem, but I'm also about moving towards solution. And I think a forum like this help us move towards solution. I've been interested in this space, in this topic for my entire career in medicine, which has almost spanned 30 years now. And I think we're, in the words of Malcolm Gladwell, we're reaching a tipping point. We've got enough conversation, enough people interested in this topic. Number one, it brings exposure. And number two, hopefully it makes it important and pertinent to everyone, regardless of race, ethnicity, background, interest, to understand the why of its importance. And I think I want to just speak briefly to the why. You know, I am as I was introduced, my background is as a surgeon. I'm an oncologic surgeon. And, you know, the entire body can be working very, very well, but there can be one spot of disease. Oftentimes the cancers that I take out, the last one I took out last week was 2 centimeters, but it impacted the entire body. The patient was losing weight. They had lost their appetite. They could no longer function in their job. It had an abnormal impact on their entire quality of life and their future outcome. We spent resources and effort and 6 months getting prepared for surgery. And with surgery, we were able to successfully remove that tumor. What we see now in our society with health disparities is that type of tumor. You know, the importance of it is our entire population cannot be its best until we attack the site of disease. And so that's the why of it. It's not just to make Black people or brown people better. It's to make our entire society and our entire economy better by helping everyone be their best. And if you want to make it faith-based, it's Ephesians 2:10. The Bible says we are God's workmanship. It says also that another version of that is masterpiece, created in Christ Jesus to be who God called us to be in the first place. And so what we're trying to do is to help everyone be their best so that our entire society and population can be its best. Thank you for allowing me to be a part of this.
Thank you all. I want to open with actually a conversation that we were having this morning before the official forum started. As these experts were getting online, I just asked Dr. Gray to give us an update on the vaccine rollout in Knox County and from UT Medical Center. And that was, his response was full of interesting insights. So I'm actually going to just ask that question again for this whole audience. Dr. Gray, if you'll share some of those reflections again.
So I think just from a vaccine uptake standpoint, I think we've seen an evolution. I think there was, you know, we did a survey, I guess, back in November before Pfizer EUA and Moderna's EUA were issued. And we had probably 48% of our population, our team members, that said that they would definitely take the vaccine if offered. You know, let's fast forward 3 months. We've had about 56% of our team members that have been vaccinated. That is excluding those who have been impacted by COVID or who have tested positive for COVID. But 56%, which is up slightly from what the initial survey said. In the underrepresented communities, we've launched an initiative that takes the vaccines to those communities to try to overcome some of those barriers of access and trust that would preclude those populations from receiving the vaccine. I'm sorry, those are my kids in the background. From receiving the vaccine. And I think what we've seen with education and establishment of trust and increased uptake in the vaccine in underrepresented communities. So I'm not sure there's a disparity that exists between, you know, underrepresented communities and majority communities. I still think there's an overall resistance, but I think with education and leveraging leaders who have taken the vaccine and then can give testimonies about the impact or lack of an impact, side effects that it has had on their lives, I think we're having an increased uptake of the vaccine.
Doug, in our conversation before we started this morning, you had some important insights, I think, about the sort of health infrastructure in Knox County and how that is related to these inequalities. Can you talk a little bit more about availability of physicians in different parts of our community?
Yeah, I mean, clearly the issue here is chronic disease management. That has to do with hypertension, diabetes, issues such as heart disease. There's 3 or 4 problems that are just crucial. Obesity. And one of the issues is that Knox County and the Knoxville area has an abundance of primary care physicians. I think we have like 111 per 100,000, and national average is about 91. And yet you look at the underserved areas, and I think Dr. Gray in one of his reports from the county assessment could provide that. You see that in these underserved areas, you have a dearth of primary care providers. That can be qualified health providers, nurse practitioners, PAs, or it can be doctors in general. The problem with that is that creates the inability to control those factors that lead to increased hospitalization and to the problems that we've seen. Fortunately, we have a number of areas that have been addressed. Dr. Gray's pointed out the Sampson and Haslam grouping over with the Just Lead in Lonsdale, but there's the free clinic. There's also the Interfaith Clinic. It's just we need to be sure we bolster that ability to provide primary care services in those communities to help people better manage their problems related. And then I think the thing he points out very clearly is there is a healthcare literacy issue here. A lot of people don't understand the importance of the medications. They don't understand the side effects, the effects of the medicines, the importance of managing, say, for a diabetic and keeping appropriate blood sugar levels and taking care of to have eye exams, et cetera. So I think it's a crucial thing that we empower other activities in those areas, and particularly we get the clergy and the churches and other leaders provide the information that's necessary that we can help people understand this is crucial to move forward and try to alleviate that 2.7 year gap that's developed in the last year. So that's what I was trying to bring. I would mention, however, in comparison to Dr. Gray, is that on a national basis, the Black community is 12.5% of the overall community, but on a national basis, only 5.4% have been immunized, whereas the white population, it's about 60.8, and 60.8 of the vaccines that were given to the whites. And therefore, we have to come out to understand that as a COVID epidemic takes place, and again, Dr. Gray is correct, whenever you have a weakness in the society, it allows things to happen adversely from a cost and also for the damaged community, but also these variants that we're seeing are happening because people are not immunized. If people are immunized correctly, you won't see this UK variant or see it so much the Brazilian or the South African variants. We have to have everyone involved in these immunizations. So whatever we need to do, it's crucial that we move forward continually in the future.
One of the issues that often comes up in these conversations is mistrust, and that there's healthcare literacy, but there's also this issue of trusting the healthcare system to do what's in the best interest of its patients. Dr. Everson, can you talk about mistrust and maybe how you see mistrust in your practice and ways that it can be overcome?
I think that mistrust is definitely a big issue in communities of color. And one of the ways that I see that that could be overcome is by having more, I mean, studies have shown that if you have more physicians or healthcare workers of color, that there tends to be an increase in trust in the population. And one of the things that I wanted to bring attention to are maybe having more pipeline programs to get students into the medical field. Like, I feel like that's where there's a huge disparity, is that we're not, I don't want to say allowing, but maybe that people of color maybe don't have, as Doug was saying, the education in terms of knowing about programs to get them to the next level. And this really starts, like, a lot of people think like, okay, this starts from, you know, in college or while you're in pre-med. But from my experience, I feel like it starts from way when you're almost in elementary and middle school. We have to start with science. Like, if kids are not engaged in science and interested in science, then it's hard for them to get to that next level and be like, okay, yes, I want to become, you know, a physician or a dentist or optometrist or anything, you know, in that nature, or even engineering. Like, if we don't get kids to be exposed in those areas. And there are a lot of programs through universities. There's particularly one called the HCOP program that it's a federally funded grant that a lot of universities use to get people of color into healthcare professions. And I just find, you know, I have kids, you know, my kids are college level age now, but even as they were going through school, I didn't find that there was enough information out there about those topics and to kind of guide children into those areas of study. You know, Jim mentioned that, you know, I was from Jamaica and I grew up there, and the way we look at science and try to engage children in science is completely different than the experience that my children had growing up here. And, you know, I just feel like if maybe we invested a little bit more, I know that we do have STEM programs now that are trying to get kids engaged in that, but I don't feel like it's widespread, especially within the public school arena, to get children interested in like biology, chemistry, physics in particular, because at the end of the day, those are the subject areas that they're tested on in order to gain admittance to these schools later on. So, you know, it's hard if you don't have a strong background in that to then all of a sudden tell somebody who graduated from, let's say you graduated from college with a business degree, well, okay, now you have to go and learn, you know, all these years of biology, chemistry, and physics, because they don't have that foundation from before. So I think that that would be a big area that we could tackle in terms of, I don't want to say from inception, but from, you know, making a change at an earlier age in the development student.
Thank you. Dr. Gray, there's a question in the chat about can we dig in further into the reasons for this mistrust? Why is it that the medical profession doesn't have the full trust of Black Americans? Do you want to take that one?
And I think maybe Dr. Everson alluded to it in her opening comments. It's just the history of the country. I mean, we're you know, African Americans in this country, you know, for 350 of our 400 years in this country have been less than, not equal. I mean, just by the laws on our books, we've been less than. And so it's pretty hard to undo that in just a generation or two. So there's historic mistrust. And then just in our recent history over the last 50 to 75 years, top of mind for a lot of African Americans is the Tuskegee experiment. And again, that started now some 70 or 80 years ago. That study finished in 1972, or was uncovered in 1972. But that legacy, that story is handed down from generation to generation, which is the evaluation of tertiary syphilis, untreated tertiary syphilis in the Black population. And so that immediately harbors or generates a mistrust for academic medical centers. When a lot of our populations here research, we're a research center, they think they're the subjects for the research, which is not unprecedented in this country. And so I think it's going to take, we can't expect this, the sentiment from Black Americans toward healthcare systems to turn around overnight. I think it's going to take a long time to undo the wrongs that have been done in this country. But I don't think it's impossible. And I think we're making strides toward that. But we've got to engage, as I've been in the underrepresented communities, even me as a Black provider, they say part of our trust long-term in you is that you won't come in and do your project and then leave, get your results and then leave. If you're going to be with us, you got to be willing to be in for the long haul. And so, some people aren't willing or haven't been willing to do that. And they're looking for immediate results to report. But I think, the things that we're talking about on this call today and some of the things that we're working on that Dr. Leahy has alluded to, we will not see the fruit of in our lifetime. These are things that my children may see the fruit of. My oldest daughter's pre-med right now. And so these are things that she may see. She may see some differences in the results, but we've got to be willing to dig deep and start to lay a foundation that hopefully can be built upon in the future.
Dr. Leahy.
Can I comment?
Yes, please.
Yeah, part of this, and I think both Dr. Gray and Dr. Everson have commented on, is the ability to engage the younger people in this endeavor. I think part of the problem right now is, if we look at what happened the last year, that every student is behind about 111 days on their reading skills and 215 days related to their math skills. So I think that, part of the problem is engagement early on. Pete DeBusk is on MedPAC, which is advisory group to Congress. And I went down and looked at the University of Alabama in Tuscaloosa, probably about 1.5 years, 2 years ago. And one of the things they were doing in Alabama is that they would identify, particularly in the rural areas, some of the really bright students that were there, and they would use navigators to help them, pick them out. What do they need to bolster them? Some of them needed additional information or education to prepare them, for example, to go as a Black doctor back into Alabama. And they were able to capture that. And then when they came out of those rural areas, sometimes they still couldn't catch up in college. So they allowed them to have an extra year in terms of doing biochemistry or something like that. So they navigated those people through. They picked out those people who really had an interest in it. And because of lack of resources within their educational system, they found those gaps, fulfilled those gaps, and were able to move forward. It's clear that we need more Black physicians. The AMA, American Medical Association, has been very committed to this, understanding that a lot of the prejudices had took place in the medical profession many years ago, and to some degree at the present. We've got to address the issue of Black physicians, Black nurses, and also the ability to have mid-levels such as nurse practitioners or PAs. So I think it's a commitment on our part. Unfortunately, what we see happening is, like at the state legislature, they're more interested in the kneeling at a football or basketball game than they are correcting the 215 days that we see gaps of developing. And I think we have to, as a concerned citizens, reemphasize the importance of the Black physician in these communities, providing the level of service, reinstituting the trust that's necessary to move forward.
And I'll just mention to those listening, there's a great book called, I think it's called Black Man in a White Coat, that was published several years ago about a man's experience going through the medical training system in this country. And it was really eye-opening to me. So I encourage all of you to pick that up if you're interested. In our discussion about trust, we've kind of focused on adding Black physicians to the mix, or Black healthcare practitioners, as a way of bridging that gap. I think one of the things that has gotten a lot of attention recently in this literature is whether white physicians or our current medical system treat Black patients equally. And after, I don't know if many of you may probably remember when Serena Williams became deathly ill during the birth of her daughter. And after that happened, she shared a story of being in the hospital and saying over and over again, something is not right, and feeling like she wasn't being heard. And there was lots of commentary that is common, that Black patients in our system are not heard and don't get equal treatment. And I just wondered if there were reflections on that. And Doug, maybe I'll start with you.
Yeah, I think part of it is trying to get an understanding of what we need to do to be able to understand the patient better. Sometimes it's we do not, and I think this is true of physicians in general. We need to be better able to relate to those patients in terms of their culture and their understanding of their conditions. And I think there's a need among all of doctors to do a better job of that, because this is a day of empowerment of patients. So whether there's a cultural breakdown because of a lack of Black physicians, or whether there's a lack of understanding of their conditions, or moving out into those areas that are underserved and providing those level of services, I think the medical profession has got to renew its concern for that and its commitment to the Black community to move forward on it. That'd be kind of my reflection on it.
Dr. Everson, anything to add to what Doug said on that?
Yeah, I did read the article of where Serena Williams was, apparently both her and Beyonce, I believe they had kids within like a month of each other, and they both had health scares during their deliveries. It's hard to imagine that even with their wealth and status, that this still did not help them to overcome that barrier of potential mortality in childbirth. This is a worldwide problem, not just a problem here in America. And I believe she knew that she had this history of blood clots, and she had asked for a CT and for blood thinners, and she was dismissed by the nurse and physician, probably politely so, but it's kind of like, sometimes I think physicians may feel tested if the patient suggests something to them that they didn't first think about. And anyway, eventually she was able to get the care that she needed, but she did want to bring light, and I wrote this down so that I would get it right. But she did want to bring attention to this worldwide problem that over 2,000 infants die, a year. I'm sorry, it's over 2.6 million newborns die each year. This is according to UNICEF, and 80% die from preventable causes. There are solutions to these problems, for instance, having more midwives, clean water, and basic drugs. And I did want, when we were doing our small groups, when we were doing the Love is the Way book, I know that we had a lot of questions, and I've even seen a few comments pop up here that what can we do, or what can people in the white community, and just in general, what can people do to help? And I did want to point out that that's one way that we all can help, is by donating to UNICEF or other such organizations that are fighting against this systemic problem where we have newborns dying, just for lack of basic needs, within whatever country they're in. But definitely here in the US, it's hard to imagine we're a first world country, and even some of our greatest superstars like Serena and Beyonce are facing these problems. I have been that person. I remember going through my first pregnancy and bringing, to light an issue that I was having to my nurse practitioner, and she kind of dismissed it. And I ended up in the emergency room 2 days later because it was not just a simple backache from being pregnant. And I ended up having to have a procedure and all of these other things, that led from that. But, again, it goes to show that regardless of your education status, that a lot of times that as patients, we're dismissed.
I would follow this up too. One of the things that is happening with medicine and payment of physicians and services is a movement for value-based care. So much of it has been fee-for-service. What we're trying to do, I noticed within Summit, our organization, et cetera, is to move for social determinants. So that part of the way that you realign this is to try to focus on those needs in the community and realign some of the resources that are there to address these concerns that would be a quality parameter as it were related to the athlete you mentioned, but more importantly, look at the issues within the community and align payment commensurate with addressing those social economic determinants. So some of this has to do with a change in some of the ways that we're moving forward on it. And I think the medical community, I'd be curious what Dr. Gray says, is trying to move to try to fill these gaps and try to help the community out moving forward.
I'm glad you said that, because I do want us to talk for a minute about the public policy implications. Dr. Gray, can you share, Dr. Leahy mentioned in his opening comments about Medicaid expansion, kind of what are the public policy changes that you think would be most effective in reducing inequality, in pushing towards a more equal healthcare system?
Yeah, clearly, if more people were insured, let me back. The lack of insurance is a barrier to healthcare access. So if we had more people that had access to healthcare coverage, then I think that would potentially improve the outcomes, but it doesn't solve the whole problem. I think Dr. Leahy was alluding to the social determinants of health. When you look at the social determinants of health, although there are 5 of them, they interact with each other. So for example, if you solve housing insecurity, you don't solve the problem. If you solve the access issue, you don't solve the problem. If you get people adequate employment, you don't solve the problem. You have to tackle all those issues in parallel. So I say that to say, just because we have, if we had Medicare for all, if we had Medicaid expansion, or if we took the dollars that we think we're going to save in the Tennessee block grant and use that to expand healthcare coverage, we would not solve the problem without tackling all these other issues as it relates to trust. And I think Doctors Everson and Leahy were talking about culturally competent care for our population, regardless of who the patient is. You don't approach all patients the same, regardless of what color you are. And we're not going to, just to be plain, we're not going to hire enough Black and brown doctors to see every Black and brown patient in this country. It's not going to happen. It hasn't happened in Dr. Everson's or my career, and it probably won't happen in my kid's career. But what we can do, and I saw that in the chat, what can the white community do? What we can do is understand the value, first of all, of each individual patient and each individual member of our community, but also understand the differences that may exist along racial, ethnic, cultural, geographic boundaries. I ask all of my patients where they're from, and based on where they tell me, I ask different questions because I know some of the characteristics of Appalachian disparities, not just Black and brown disparities. So I agree. Again, I think there are policies out there that will help, but it has to be done in parallel with focus on all the other issues that are barriers to access to care.
Dr. Leahy, do you want to say more about the Medicaid block grant, kind of your perspective on that issue?
Well, of course, part of what they're attempting to do was under the previous administration was take a fixed amount of money and bring shared savings. They believe they could be able to create an amount of money that they would be able to fund certain healthcare programs, and therefore it would save money for the state to address those needs, and also it would be monies that go back to the federal government. The concern is that so many of the people who participated in of the different communities, the underserved communities, were not really necessarily convinced as they saw the TANF funds seem to be sequestered in Nashville and not utilized. So they had suspicions related to that. As the new administration's moved in, there is a number of people that are from the old Accountable Care Act, and they believe that the Medicaid expansion basically needs to be done in a manner that is not a block grant, but to assure essential services so that there's not cutting out of certain things that are necessary, child care, maternity care, et cetera. So therefore, probably what you're likely to see, even though they got the block grant, is if there's good likelihood that'll be reversed in the current administration. If not, there may be a huge delay, and that could be 2 or 3 years, for which you've got 300,000 people who's not receiving services, which we believe is very important to get those people covered. A lot of them are essential workers. Again, you remember that Medicaid covers those people below the poverty line. It's those people that are roughly about poverty line to 130% would be helped through this. So the bottom line is, at the present time, there is concern whether this block grant would move forward. I was the chairman of the QIO. We oversaw a lot of the things that went on with the Medicaid program. Medicaid program's always been heavily into managed care. They've done an excellent job of it. So it's a little bit hard to understand the savings that comes out of the block grant, and therefore the delay that potentially might take place to cover those people, who basically be 300,000 people who would be very important to have that level of coverage, particularly this time of the pandemic, but also in the future.
And to be clear, we're already delayed some number of years, because we could have expanded Medicaid in 2011, 2012. Is that right? And we're already 9 years behind.
Right. You remember I wrote that letter about 6 years ago. Bill Haslam wanted to move forward on it. It failed in the legislature. But basically what it would have meant that for this 10-year period of time, the state would have provided roughly $100 million, for which they would receive $10 billion. And the hospitals were going to provide the $100 million. So it would not have really cost the state any money at all. As we've looked at the states who have expanded, not only has their quality gone up, but also the additional savings to the overall budget of the state showed net savings to them of those Medicaid expansion states. Tennessee is one of the 12 states not expanded. Most of them are states that have high Black populations and underserved communities, and have been shown that the mortality and hospitalizations are higher in those states who've done the expansion related to them. So, it's clearly a lack of leadership at the state level to move forward on this, and it's going to be a time to see, as the new administration acts on this, which most likely will be to obviate is to get rid of the block grant, that these people will be in limbo.
The former Governor Haslam was part of a panel this week where they asked him what his greatest regrets were, or his biggest mistakes were during his 2 terms as governor, and that was his example, was his failure to get the Medicaid expansion through. And he told that story on a procedural basis, like I did it wrong, and here's how I did it wrong, and if I had done it this other way, I think I could have gotten more people on board and gotten it across the line. But it was really remarkable to hear him talk about that. I want to talk for just a minute go back to COVID for a few minutes. And Dr. Gray was sharing with us this morning some details on the local infrastructure, and more even just the partnerships that have been put together, partnering churches with the Knoxville Health Department, with UT Medical Center. Dr. Gray, can you just tell us, those of us who really know nothing about this, can you tell us sort of what the day-to-day partnerships are looking like, and who's partnering with who, and how successful do you think those partnerships have been?
Yeah, so as you recall from my opening comments, we've talked a lot about disparities for 25 plus years without any pointing towards solutions. I think we're finally getting to a point where we're talking about how we can solve, or at least discussing how we can solve this problem. A big word for me is trust, and another big word for me is strategic partnerships. Everyone doesn't have access to every area. And I'll use since it's my organization, I'll use the University of Tennessee Medical Center as an example. University of Tennessee Medical Center has a great legacy in some communities and not so great in others. And so as we sought to reach out to solve the access issue as related to COVID education and vaccination, we knew that we didn't have access to some of those, or immediately and timely access to some of those communities to make a difference. And so really, I think part of earning trust is understanding what the leadership structure looks like in the communities that you're interested in. And it doesn't have to be underrepresented as any community, but that leadership structure actually probably is different in the Black and brown community, at least in the African-American community in East Knoxville and the Lonsdale area. it's the pastors are at the top of that leadership hierarchy, and Greek organizations are probably pretty close. And so we leveraged our relationship with them. And then from a healthcare provision standpoint, you know, like the project that we did in Lonsdale at the Haslam Sansom complex, we knew that UT Medical Center probably wasn't ready to do that or didn't have the relationships to put that health center in that ministry complex. But Cherokee Health did have that relationship. And so we leveraged a partnership with them and with the Emerald Youth Foundation. But as it relates to COVID, we partner with area churches. We've been on a ministry call called the Faith Leaders Health Initiative since May 1st. We meet weekly on Thursdays. Started out as a conference call, now it's turned into a Zoom call. But we talked about everything COVID. And, you know, I've been fortunate enough to be the medical advisor for that call. But, you know, again, going back to being consistent and being available, you know, I've been on that call. I probably missed a handful of weeks due to different things, been in the operating room. But most weeks I'm there, and those pastors have my phone number. They call me at 10 o'clock at night and say, I have this issue, or I have this family coming into town. What should I do? And over time, I think that has made a difference. I think we've seen a massive turnout for our vaccination efforts in East Knoxville. We did one at Mount Olive 2 weeks ago. Last week, we were at Mount Calvary. We had 425 at the first event and 390 last week, and we'll be in Lonsdale this week. But again, we could not have accomplished that had not it been for what we had, the groundwork we'd laid since May 1st. And secondly, UT Medical Center could not have been the provider of the vaccine effectively if we did not have the relationship with the churches, and then next week with Emerald Youth and Cherokee Health.
Dr. Gray, there's some questions in the chat about, you know, about whether the ways in which people are signing up for vaccines in Knoxville is keeping some people out of the process. So is the internet-based process an inhibitor? Can you talk about whether the efforts you're describing, you think, are working around that?
Yeah, so I will say, first of all, that I think the access to sign up is a barrier. You know, we make assumptions, and that's what we're talking about on this call. We're talking about, not talking about people that are intentionally trying to be mean. Most people, it's just biases that you don't even know exist. But we create a system where we assume everybody has internet access. We assume everybody has high-speed internet access. We assume everybody checks their, you know, knows how to use the phone or has access to a cell phone. And we have you sign in that way. And then we have you stay on the line for 45 minutes waiting for someone to pick up the phone if you're using that phone. But that biases against people that don't have internet access in our urban communities, but also in our rural communities. There's a lot of people that don't have broadband access, as we found out last year when we got ready to do remote learning, that not everybody had equal access. So I think those are barriers that weren't well thought out in the beginning. We're trying to mitigate those barriers by, we actually leverage the Black pastors and the Black churches, and they know their parishioners. They reach out to them. They know if they're eligible by TDH criteria, and they give us a handwritten list with the demographic information that we need. And then it's our responsibility to enter that data where it needs to be entered. So we've turned the dial back probably 30 years in how we're accessing this information and working around some of those barriers. And again, some people would argue that now you're cheating the system. You know, I would argue against that. Again, the disease analogy that I gave before, when you know where the focus of disease is, you do everything you can to get that disease out, because it ultimately impacts the entire body. Said another way, if we don't reach herd immunity in our community, our entire community is impacted. Our businesses are impacted. The future status of our economy is impacted.
That's a really remarkable story, and honestly, not something that you hear when you take in kind of standard news media. I didn't appreciate that there was that much effort going on to getting people signed up who don't have internet access. Dr. Everson, I've got two questions for you, a little bit different from each other. One, there's a question in the chat about dental care in Medicaid. Can you talk about the importance of that? And then lots of folks, including some parents on the call, who want to know what's different between Jamaica and Knoxville on the science education front. They want more details. So different questions, but both headed for you.
Okay. Well, just to touch a little bit on dental care and Medicaid, what a lot of people don't know, and they call our office really almost every day with this question, is that Medicaid dental care in Medicaid is cut off at the age of 21. So that's a really important factor in this discussion, because if you haven't been receiving regular dental care, in your childhood, and then, now as an adult, as the general population, that you're going to have dental problems later in life. Basically, if you're on Medicaid, you are cut off from that system. Now, there are a few exceptions to that rule. I believe that there are a few people who are on Blue Care that have access to dental, where they will get limited dental services payable by insurance, such as dentures. Sometimes on Medicare, you can get a few services as well, but it depends on the Medicare plan that you're signed up for. But really recognizing that within TennCare specifically, dental care is considered really for children. And so the age cutoff is 21. I hope that answers that question.
I think so.
And with regard to the difference between Jamaica and Knoxville, for me personally, I just see like a lot of differences in our education system. I feel like, and I don't know if it's just third world countries in general, but I know that, from an early age, education is just, it's almost not literally, but figuratively, like beat into you. So we start testing at a very early age. Like I know that we have TCAP here, or what used to be TCAP when my kids were in school. In Jamaica, we have what used to be called Common Entrance, but which is now called PEP, which is like an entrance exam into what would be the equivalent of your middle school. And it's very competitive in nature. And sometimes that competition kind of drives children to excel further and to kind of dig deep within themselves to get to that next level. And then, I can only really speak to my high school, but well, I shouldn't say that. Even other high schools within the corporate area, because we have a brilliant doctor over at ORNL, and she went to one of the high schools in the Kingston corporate area. And she's one of very few Black female, she might be one of the only Black female physicists there. But, and she commented the same thing to me on that everybody at, her place of employment was saying, oh, you're so brilliant, and, you've done this and you've done that. And to her, she was just like, I wasn't really even the smartest person in my class, I don't know. I don't know how to give you a concise answer on that, except to say, let's say I had 30 kids in my biology class at the time that I graduated, and at least off the top of my head thinking, at least 50% of them are now doctors. So it's just, I think it's just a different emphasis, and probably a good 25% of the graduating class are engineers. And it may just be the way our system surrounds the University of the West Indies, where they have the medical school is actually in Jamaica, and they have the engineering school in Trinidad. And so the access to the education is right there for the students. And so with that, to me, I feel like the teachers have just really invested, in their students. I know Ashley is listening, and my biology teacher is actually her grandmother. And so we develop a close relationship with our teachers, and our teachers really invest in us getting to that next level. So maybe that's the difference, is the teacher involvement.
Okay, thank you, Dr. Everson. All right, last question. It's a short one for Dr. Gray. Has St. Luke's Church in East Knoxville, is that part of your network? Do you know?
Not that I'm aware of. That name does not resonate with me, but I would have to, I don't know that location. If they can put in the chat where that location is, I can confirm that.
Okay, Monty, that's on you. All right. So while Monty's doing that, I just want us to take a minute and thank these experts for giving an hour of your Sunday morning to us. This was really enlightening, and we really appreciate you being here. I'm gonna wrap us up really quickly by just sharing with you what's coming up for us. Just a minute here.
Just want to make, while you're pulling up can I share one thing?
Please.
I just want to, just as a closing 10 seconds, want to say to the group on this line, and I think it would resonate with everyone, we can't do this without the love of the gospel. I mean, we're talking about the need for education. We're talking about the need for access and health, but we cannot do this without the gospel. And without first, I don't think, blacks and whites or whatever the racial groups can be reconciled to each other before we're reconciled with Christ. I don't even think it's possible. And so as you go out, I think you have to continue to present the gospel first, and everything else follows.
Those are beautiful words to close. Thank you for that. Okay, I'm gonna just give a quick pitch for what's coming up next. So next weekend, Traces of the Trade. Caroline Vogel, do you want to unmute and give a couple details on that?
Sure. So next Saturday morning, 8:45 on Zoom, we're going to view, anyone who's interested to view the documentary Traces of the Trade. And there will be a discussion following that Saturday morning. Sunday morning, during the Sunday school hour, Dane and Constance Perry will be with us to discuss the viewing of the documentary, but also to talk about racism and how it applies specifically to the Episcopal Church and its history. Dane Perry will be preaching at the 10:30 service, being live streamed. And then at 5 o'clock next Sunday evening, there's going to be a panel discussion in honor of Absalom Jones. So in celebration of the feast day for Absalom Jones, 5 o'clock panel discussion on Zoom. We hope you will register for all these events. You can find the links in your Heavenly Post or on the website. Thanks.
Thank you, Caroline. Okay, and then on March 14th and 21st, we're going to tackle two other issues, that kind of inequality issues. On the 14th, we have our very own Christy Starks-Wynn, and also Cedric Jackson from the Emerald Youth Foundation. And we're working on a third speaker. And so these folks are going to share with us their insights on education disparities in Knox County schools and outside of them. And then on the 21st, we're going to talk about labor market inequalities. So we hope that you'll join us for the next 3 Sundays of programming. And we're going to close out Mary Laments. If you'll unmute, Mary's going to lead us in prayer to close.
Let us pray. Look with knowing kindness, O Heavenly Father, upon the people in this land who live with injustice, terror, disease, and death as their constant companions. Have mercy upon us. Help us to eliminate our cruelty to these, our neighbors. Strengthen those who spend their lives establishing equal protection of the law and equal opportunities for all. And grant that every one of us may enjoy a fair portion of the riches of this land through Jesus Christ our Lord. Amen.